Let's talk about approach to suspected acute infectious diarrhea. First, we will assess for high-risk features, which are bloody stools or high-grade fever, severe disease, mostly these patients are hospitalized, elderly patients or immunocompromised patients, and diarrhea more than 7 days. If none of these high-risk features are present, we will do supportive care with fluid replacement only. But if we have high-risk features, we will do stool studies, which include fecal leukocytes, multiplex PCR testing, stool culture. For people who had recent travel, we will consider ova and parasite testing. And for people who had recent hospitalization or antibiotic use, we will consider testing for Clostridium difficile. If stool studies shows non-inflammatory diarrhea, we will consider antibiotics for severe disease, for elderly, immunocompromised patients, and pathogens with low infectious dose, for example, Shigella. But if testing shows inflammatory diarrhea, which includes bloody stools and positive fecal leukocytes, this is very important. We should differentiate between Shiga toxin producing Escherichia coli and non-Shiga toxin producing Escherichia coli. For that, we will do PCR. If we say that it is the non-Shiga toxin producing Escherichia coli, we will do same management as we would do during non-inflammatory diarrhea, which is consider antibiotics only during severe cases for elderly, immunocompromised patients, for pathogens with low infectious dose, for example, Shigella. But if it is Shiga toxin producing Escherichia coli, we should avoid antibiotics because there is a high risk that HUS or hemolytic uremic syndrome will occur. And we should do intravenous volume expansion. Let's repeat one more time. Empiric antibiotics are not recommended for bloody diarrhea in children because they increase the risk for hemolytic uremic syndrome, HUS, if the causative pathogen is high risk Shiga toxin producing Escherichia coli or E. coli 0157H7. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about approach to adenophagia and dysphagia in patients with HIV. Patients with AIDS are at high risk for infectious esophagitis with Candida albicans, which is the most common, herpes simplex virus, and cytomegalovirus. Patients with concurrent oral thrush are generally treated with empiric oral fluconazole. Those who do not respond to fluconazole or have an evidence of thrush often require further evaluation with upper endoscopy and biopsy to clarify the diagnosis. When we suspect esophagitis, for example, there are symptoms of dysphagia or adenophagia, we divide symptoms as mild symptoms and oral thrush and severe symptoms but no thrush. If it is mild symptoms with oral thrush, it is most likely that Candida albicans is the reason. We will start empiric treatment with fluconazole and we will do endoscopy if no improvement with treatment occurs. If no thrush is observed and we have severe symptoms, we will do endoscopy for likely viral etiology observation. It can be herpes simplex virus or cytomegalovirus. If during endoscopy we see white plaques, it is again Candida likely, we will treat with fluconazole. If we see large linear ulcers, cytomegalovirus is likely, we will treat with ganciclovir. If we see vesicles and round ovoid ulcers, herpes simplex virus is likely, and we will give acyclovir. And if we see aphthous ulcers, treatment is symptomatic. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about common causes of foodborne disease. If the vomiting is predominant, most likely the cause is Staphylococcus aureus or Bacillus cereus. If it presents with non-inflammatory watery diarrhea, the causes can be norovirus or rotavirus, Clostridium perfringens, enterotoxigenic Escherichia coli, Vibrio cholerae, Listeria, parasites like Giardia, Cryptosporidium, or Cyclospora, or intestinal tapeworms. If the diarrhea is inflammatory, we see blood or mucus in the stool or positive fecal leukocytes and/or red blood cells. The causes can be Shiga toxin-producing Escherichia coli, Shigella, Campylobacter, Salmonella, Vibrio parahemolyticus, or Yersinia. If we have extraintestinal symptoms, we can suspect Clostridium botulinum with descending paralysis, Listeria with meningitis, Vibrio vulnificus with cellulitis and sepsis, and hepatitis A virus with jaundice. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about the evaluation of neonatal cyanosis. If the cyanosis is on the distal extremities and lips and SpO2 is normal, it means we have peripheral cyanosis and we can do just reassurance. If the cyanosis is mucosal or diffuse and SpO2 is decreased, at this point, of course, we will administer oxygen or O2. If SpO2 increased after oxygen, that indicates pulmonary pathology. Specifically, we need to consider persistent pulmonary hypertension of the newborn, particularly if we have different cyanosis. And because we suspect pulmonary pathology, we will provide respiratory support, which is intubation, ventilation, and check pH. If after administering oxygen, SpO2 is unchanged or not stable hemodynamics, we will think about cardiac pathology. We will give prostaglandin. The cardiac pathology include cyanotic congenital heart diseases, transposition of the great arteries, during which we will have right to left shunt. And by giving prostaglandins, it will keep open ductus arteriosus and we will have connection of left and right heart. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about the evaluation of red urine. If urine is red, let's talk about hepatitis B post-exposure prophylaxis. When we say post-exposure, we mean following exposure to source patient with active infection, which is positive hepatitis B S antigens. We need to determine status of exposed patient. If patient is previously fully vaccinated and adequate post-vaccine response is present, which is anti-hepatitis B S titer is more than 10 milli-international units per milliliter after completing vaccine series, no post-exposure prophylaxis is needed. But if patient is previously fully vaccinated and we don't know about post-vaccine response, we will check anti-hepatitis B S titer and serology, and inadequate titer and non-immune cases will get hepatitis B immunoglobulin and vaccine. And in the cases when vaccination is incomplete or we don't know about vaccination status, we should determine infection status, which is to do serologic testing. If serologic testing shows prior or current infection, which is positive anti-hepatitis B C antibodies, and hepatitis B S antigen can be positive too, no post-exposure prophylaxis is needed because we have prior or current infection. But if serologic testing shows that the patient was never infected, which is negative hepatitis B S antigen and negative anti-hepatitis B C antibodies, we should administer hepatitis B immunoglobulin and vaccinate the patient. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about the evaluation of acute kidney injury in patients with advanced liver disease. First, we will check if urinary obstruction is present. If yes, we will need to manage that and see if the symptoms are improving. If no improvement, HRS or hepatorenal syndrome is suspected. If we don't see any obstruction, we will collect urinalysis, and if it is abnormal or any specific condition is found, we will treat it. For example, acute tubular necrosis or acute interstitial nephritis. If there is no improvement, again, HRS is suspected. If after collecting the urinalysis, no abnormalities are found, we have a bland urinalysis, we suspect hepatorenal syndrome or HRS. We need to measure urine sodium. If we have a very low urine sodium, less than 10 milliequivalents per liter, again that supports hepatorenal syndrome. We will give trial of volume expansion, for example IV fluids, IV albumin. If there is no improvement, HRS is confirmed, and we will give splanchnic vasoconstrictors, and we will seek liver transplant. But if it improves after volume expansion, that's perfect. We will continue volume expansion as needed to correct the intravascular volume depletion. Here we have very important points that will help us for differential diagnosis. Due to the remarkable renal sodium avidity in HRS of very low urine sodium, less than 10 milliequivalents per liter, in contrast with classic prerenal acute kidney injury, during which we will have low urine sodium less than 20 milliequivalents per liter. During HRS, the low urine sodium less than 10 is a helpful diagnostic clue. Hello everyone, it's Schematic Med, and today we're going to talk about management of lower extremity proximal DVT or deep venous thrombosis. If patient presents with lower extremity proximal DVT, which is above the knee, assess if the patient has limb-threatening DVT, which means evaluate for compartment syndrome, which is a surgical emergency caused by increased pressure within a closed muscle compartment leading to severe pain, nerve damage, and potential necrosis of the tissues. And I'm sorry if I pronounce this wrong. We need to assess for phlegmasia ceruleus dolens, which is large occlusive iliofemoral DVT with venous limb ischemia and gangrene, which presents with cyanosis, bullae, massive edema, and extreme pain. If we have anything the above stated, we should do thrombolysis. It can be systemic or catheter directed, or thrombectomy, where percutaneous or surgical. If none of these two conditions is present, we need to assess if we can give anticoagulation. For example, is there any active bleeding or bleeding that is difficult to treat, intracranial hemorrhage? If we can give anticoagulation, obviously we will give it. If we cannot give it, we will consider placing IVC filter, preferred retrievable one. For IVC filter placement, the relative indications are clot that is spreading despite anticoagulation and decreased cardiopulmonary reserve, for example, impending right ventricular failure. The IVC filter traps clots in transit, reducing the risk of clinically significant pulmonary embolism. Once again, IVC filter is the option for patients with acute DVT and absolute contraindication to coagulation, for example, intracranial hemorrhage, active or uncontrollable bleeding source. Thank you, bye. Let's talk about management of postpartum thyroiditis or PT, same as autoimmune, painless, silent thyroiditis. We will confirm diagnosis with increased T4 and T3, decreased TSH levels, increased thyroglobulin levels, decreased radioiodine uptake, positive TPO antibodies, same as thyroid peroxidase antibodies, and negative TR or thyrotropin receptor antibodies. Postpartum thyroiditis is an autoimmune disorder characterized by lymphocytic infiltration of the thyroid gland and disruption of thyroid follicles, occurring less than 12 months after childbirth. It causes a self-limited hyperthyroid phase due to release of preformed thyroid hormone. Management includes a beta blocker to attenuate adrenergic symptoms, but specific antithyroid therapy is not needed. As I mentioned, postpartum thyroiditis has hyperthyroid phase, hypothyroid phase, and euthyroid phase. During hyperthyroid phase, T4 and T3 are increased and TSH is decreased. We will give only beta blockers for symptom control. During hypothyroid phase, T4 and T3 are decreased and TSH is increased. For management, we will ask if the patient is breastfeeding or attempting pregnancy, if the patient has hypothyroid symptoms or TSH is increased more than 6 months, and we'll give levothyroxine. During euthyroid phase, TSH, T4, T3 are normal, and we should wean off from levothyroxine as tolerated, and annual TSH should be measured. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about pathophysiology of massive pulmonary embolism. Patients with massive pulmonary embolism usually present with pleuritic chest pain, signs of low arterial perfusion, for example hypertension and syncope, acute dyspnea, and tachycardia. The thrombus increases pulmonary vascular resistance and right ventricular pressure, which will cause right ventricular hypokinesis and dilation and hypotension. You can see here I drew schematically the heart, and we can see right ventricle and left ventricle, and we can see the thrombus. So this thrombus will increase right ventricular pressure. That will cause decreased hypokinesis of the right ventricle and the right ventricular dilation. Right ventricular hypokinesis will decrease the right ventricular outflow, and we know if the right ventricular is giving less blood to the left ventricle, it means that left ventricular preload is decreased. If left ventricle receives less blood, obviously it will give to the tissues less blood too. So that is what we call cardiac output. So the cardiac output will be decreased and blood pressure will be decreased too. Obviously, if left ventricle is giving less blood to the tissues and one of the tissue is right ventricle too, and a right ventricular oxygen supply will be decreased too. Right ventricular dilation will increase the right ventricular wall tension, and if the tension is increased, obviously right ventricular oxygen demand will be increased too. So when the demand is increased and the right ventricular oxygen supply is low, we will eventually have right ventricular ischemia and infarction, which can lead to right ventricular failure and shock. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about post-thrombotic syndrome. Most cases of post-thrombotic syndrome arise within 2 years of thrombus. The epidemiology is chronic venous insufficiency following acute DVT. It presents with leg edema, pain, which is worse at the end of the day. Ulcers can occur because of the venous stasis, and we can observe superficial venous dilation. Treatment includes exercise, for example, ankle flexion and walking, and compression like band. Let's talk about rabies post-exposure prophylaxis. If we have a case with mammalian bite with possible rabies exposure, for example, broken skin or mucous membrane contact, we need to ask what kind of animal was that, because we divide animals to low-risk wild animals, high-risk wild animals, pets, and livestock or unknown wild animal. For the last one, which is livestock or unknown wild animal, we should contact Public Health Department. Low-risk wild animals are squirrel, chipmunk, mouse, rat, or rabbit. No post-exposure prophylaxis is needed. For high-risk wild animals, for example bat, raccoon, skunk, fox, or coyote, we should try to understand if the animal is available for testing. We will talk about testing, but let's talk about the pets too, which are dogs, cats, ferret. For pets, we do not do testing, we just assess if we can do quarantine for them. So if we cannot do testing for high-risk wild animal and we cannot do quarantine for pets, we will start post-exposure prophylaxis. So when we say testing for high-risk wild animal, we mean euthanize and test. And we will do post-exposure prophylaxis if rabies test is positive. And of course, for pets, we will not euthanize them, we will just do quarantine, we will observe them for 10 days, and we will not do post-exposure therapy if animal is healthy. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about tumor lysis syndrome. When cell dies, everything that is inside the cell will go outside. In this case, we will talk about potassium, phosphorus, and purines. When the phosphorus is increased in the blood, which we call hyperphosphoремia, the body will try to excrete it in the urine, so we will have increased urinary phosphate. But calcium will bind with phosphate and will cause calcium phosphate stones. And eventually we will have hypocalcemia because it binds to phosphor and it created stones, and calcium phosphate stones will cause acute kidney injury. The purines, under the influence of xanthine oxidase, will cause hyperuricemia. Again, this will increase urinary uric acid, and uric acid stones will occur, and eventually we will have acute kidney injury. And what about the potassium? Of course, if potassium is released from inside the cell, we will have hyperkalemia, and this can cause cardiac arrhythmias. Spontaneous tumor lysis syndrome can occur in patients who have hematologic malignancies with high turnover burden or rapid replication rate. Hello everyone, it's Schematic Med, and today we are going to talk about uric acid reducing agents. Uric acid is produced from purine nucleic acids under the influence of xanthine oxidase. Then uric acid is converted to allantoin, which will be excreted in the urine. We have medication group that will inhibit the xanthine oxidase and will decrease uric acid production. These drugs are allopurinol and febuxostat. This will decrease uric acid production and will decrease precipitation in the urine and stone formation. But what should we do if uric acid is already produced? For example, high amount of uric acid is produced during tumor lysis syndrome. I talked about that in another video. We have another medication group which will increase clearance of uric acid. One of that medication is rasburicase, which is recombinant urate oxidase. This means that it is not naturally present in humans, and again, this is preferred reduction method in tumor lysis syndrome because it metabolizes existing uric acid, and it excretes in the urine as allopurinol. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about varicella post-exposure management. After varicella exposure, we should find in the case if the patient is immune to varicella. So we should find prior infection or 2 doses of vaccine. If we can find it, so we should only observe. If we cannot find prior infection history or 2 doses of vaccine, next step is to evaluate if the patient is immunocompetent or immunocompromised or pregnant or is newborn. If our patient is immunocompetent, I want to repeat, even if the patient is pregnant and is younger than 1 year old, even if the patient is immunocompetent, they fell in another group. Okay, here we exclude them. So if the patient is immunocompetent, we will do varicella vaccine within 5 days of exposure. Vaccine is still recommended after 5 days of exposure to prevent future infection, but is not effective as post-exposure prophylaxis. And if patient is immunocompromised, is pregnant, or we have a case with newborn younger than 1 year old, we will give varicella-zoster immunoglobulin or Varizig within 10 days of exposure. Thank you, bye. Let's talk about evaluation of suspected ventilator-associated pneumonia, or VAP. If we suspect VAP, first step is to do chest X-ray. If chest X-ray is abnormal, we will do lower respiratory tract endotracheal tube sampling or aspiration, and we will do culture and microscopical examination. When we wait for results of culture, we will start empiric antibiotics. What antibiotics we will use depends from drug resistance pattern at institution, but that antibiotic should cover gram-positives, gram-negatives, should have anti-pseudomonal properties, and we should consider MRSA coverage. If culture came negative, we will discontinue antibiotics and evaluate for other causes. Culture can be positive, but the outcome can be with clinical improvement with empiric antibiotics, and it can be without clinical improvement. If we have positive culture with clinical improvement, we will narrow antibiotics according to the culture results. And if we don't have clinical improvement and culture is positive, it is most likely that we have VAP or ventilated-associated pneumonia. We will consider changing antibiotics. We will assess for VAP complications, for example, abscess or empyema, and we will consider evaluation for other causes too. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about normal vitamin D metabolism. 7-dehydrocholesterol will become vitamin D2 and vitamin D3. Vitamin D2 is called ergocalciferol, and vitamin D3 is called cholecalciferol. This conversion will occur in the skin under the influence of ultraviolet rays, which comes from the sun. And mostly people can take vitamins or supplements, and they include and contain vitamin D2 and vitamin D3. Then vitamin D2 and vitamin D3, under the influence of 25-hydroxylase, will become 25-hydroxyvitamin D. 25-hydroxyvitamin D will become 1.25-dehydroxyvitamin D under the influence of 1-alpha-hydroxylase. This enzyme, 1-alpha-hydroxylase, is very important because calcium will inhibit this enzyme and PTH or parathyroid hormone will induce this enzyme. Then 1.25-dehydroxylase D will go to bones and will increase mineralization and increase remodeling. The vitamin D will go to small intestine and will do calcium absorption. This is his major effect. In the kidneys, it will increase calcium and phosphorus reabsorption, and in the parathyroid gland, it will decrease PTH secretion. And lastly, let's quickly talk about the connection between parathyroid hormone, vitamin D, and calcium. Parathyroid hormone is released from parathyroid gland. It will go to bones and kidneys. In the bones, it will increase bone resorption and will increase calcium release and will increase circulating calcium level. In the kidneys, it will increase calcium reabsorption and again will increase calcium level. And in the kidneys, we already talked about that, will increase 1.25-dehydroxyvitamin D level and will increase GI calcium and phosphorus absorption. And this again will increase circulating calcium. And very important thing, with negative inhibition, the calcium increased circulating calcium level and increase 1.25-dehydroxyvitamin D levels will inhibit the PTH release from parathyroid gland. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to talk about coagulation cascade. For me, it is much easier to remember the coagulation cascade using Arabic numerals instead of Roman numerals, simply because Roman numerals have too many lines, making things look a bit complicated. You can see here I have written everything in Arabic numerals. The coagulation cascade is divided into three parts: intrinsic pathway, extrinsic pathway, and common pathway, where the first two merge. At the first glance, you can already see that the intrinsic pathway is longer, while the extrinsic pathway is much shorter, involving only one key factor. Intrinsic pathway starts when there is damage to the surface of the endothelium. The kininogen kallikrein system activates factor 12. Factor 12 activates factor 11. Factor 11 then activates factor 9. And factor 9, with the help of the activated factor 8, activates factor 10, leading to the common pathway. So to remember, 12, 11, 9, 10. Yes, it skips numbers, but hey, that's just how it is. Now let's start extrinsic pathway. This one is super short. You just need to remember factor 7 gets activated with the help of the tissue factor, and activated factor 7 then activates factor 10, leading to the common pathway. Now let's connect this with prothrombin time, PT, and partial thromboplastin time, or PTT. The intrinsic pathway is longer and PTT has an extra T, so PTT represents intrinsic pathway. The extrinsic pathway is shorter, and PT has few letters, so PT represents extrinsic pathway. So if anything happens with one of these two pathways, either intrinsic or either extrinsic pathways, PT or PTT will change. Now, in the common pathway, factor 10, with the help of the factor 5, converts prothrombin factor 2 into a thrombin factor 2A activated 2. Thrombin then converts fibrinogen into fibrin, leading to clot formation. Finally, factor 13 cross-links fibrin to stabilize the clot. Now let's quickly talk about the medications that can affect the coagulation cascade. Warfarin primarily affects vitamin K-dependent factors. When they are inactive, the factors are 2, 7, 9, 10, as well as anticoagulation proteins like C and S. You can see that these numbers include 7, so PT will be increased during warfarin use. Next is low molecular weight heparins. This enhances antithrombin 3, which inhibits all activated clotting factors but has the strongest effect on activated factor 2, which is thrombin, and activated factor 10. We will continue other medications in part 2. Thank you, bye. Hello everyone, it's Schematic Med, and today we're going to continue the coagulation cascade medication part 2, and we will talk about methemoglobinemia. In clinical settings with warfarin and heparin, you will also see direct factor 10 inhibitors, also called active 10 factor inhibitors. This group includes rivaroxaban and apixaban, both of which are oral medications. On the other hand, fondaparinux is an indirect inhibitor of factor 10. Another medication group is direct thrombin or factor 2 inhibitors. These include argatroban, bivalirudin, and dabigatran, which is oral. This medication directly inhibits thrombin activity, impacting clot formation. Additionally, I want to talk about the factor 8 deficiency. Factor 8 deficiency or hemophilia A leads to increased PTT, normal PT. Now we know why, because the 8 factor was part of the intrinsic pathway, right? And this condition has tendency for prolonged bleeding, often requiring factor replacement therapy. Sometimes inhibitor development can occur in 25% of patients with severe factor 8 deficiency. It should be considered in a patient with bleeding refractory to replacement therapy or with increased bleeding frequency. Now let's talk about methemoglobinemia. Acquired methemoglobinemia results from the oxidation of iron in hemoglobin, which is most commonly due to topical anesthetic agents or dapsone. It presents with hypoxia, a characteristic pulse oximetry reading of approximately 85 and a large oxygen saturation gap. Additionally, some drugs and nitrites can be caused too. Inside the hemoglobin, iron should be in ferrous state, which is 2+ state, and if oxidation occurs, it will be converted to ferric state, which is 3+, reducing its ability to bind and release oxygen efficiently. This can bind tightly the cyanide, preventing it from excreting, causes dusky skin discoloration, and cannot carry oxygen. Thank you, bye. Let's talk about evaluation and management of pharyngitis. We will start from the evaluation of Centor criteria, which has 4 points: fever by history, tender anterior cervical lymphadenopathy, tonsillar exudates, and absence of cough. We need to know all 4 criteria very well, because when we do evaluation, we need to give points. If we don't have none of these, or we have only 1 present, no testing or treatment for streptococcal infection is needed. If we have 2 or 3 present, we should do rapid streptococcal antigen testing. If testing is positive, we will start penicillin or amoxicillin. If all of the criteria, which is 4 of them, are present, we can start empiric penicillin or amoxicillin. Or we can do rapid streptococcal antigen testing, and if it is positive, again give penicillin or amoxicillin. One thing that I want to mention, if we have viral pharyngitis, for example during adenovirus, rhinovirus, or coronavirus, one of the symptoms will be conjunctival injection. We call it viral conjunctivitis, and this condition is self-resolving, and we will talk in another video when we suspect viral pharyngitis, the treatment is supportive. Thank you, bye. Let's talk about evaluation of acute pharyngitis in children. If viral symptoms are present, for example cough, conjunctivitis, oral ulcers, it means we have viral pharyngitis and the care is supportive. If we don't have viral symptoms and we evaluated with Centor criteria and decided to do rapid streptococcal antigen testing, testing can be negative and positive. If the testing is negative, we will do a throat culture, and if it is negative, it means that we have viral pharyngitis, again supportive care. If we have positive rapid streptococcal antigen testing or the culture is positive too, we confirm streptococcal pharyngitis and we will give oral penicillin or amoxicillin. Thank you, bye.